Fine. I got your name correctly. Good afternoon.
Yes.
How are you doing?
Hi.
Sorry, I didn't get your name. May I get your name, please?
Tina.
Tine. Oh, great.
Yeah.
Tine. Great. It's good to have you.
Yes.
It's good to have you today. So we should start in the next few minutes. Let's say in the next 5 minutes, just to give everyone enough time to join in. But right now we are at 3:02. I can see Birara. Thank you for joining. We should start in a few minutes. For those joining, good afternoon. For those joining, we shall start in the next 3 minutes. Great. So thank you for joining us. We're just waiting for the presenter of the day to join us. But if I could propose that we start with the introductions, just get to know each other as we wait for the presenter to join us in the next few seconds. If that's okay with everyone. Great. So this is Anne Maina speaking. I'm with Mira. I'm the program assistant. A warm welcome to today's session. May I nominate randomly that we get to know each other as people join in and have the presenter coming in a few seconds. So Tim, if you don't mind going first. Ruth, am I audible though? Ruth, are you there? Could we have Tebi? Tebi.
Hi, Anne. Yes, you are very audible. Good
Great.
afternoon.
Good afternoon.
Yeah, my name is Tebi Otieno. I am a journalist. I'm in Nairobi. I write for different publications, both local and global. I major in health.
Great, fantastic, fantastic. I think you're in the right place for today's session for sure. Ruth? Or Birara? Birara? Hello. May I confirm that you didn't have any trouble using the link? Because I seem to have people saying they are not able to join in. Oh, no problem, Ruth. Okay, just Birara, are you there with us? Okay, maybe we can give it a 2 minutes or so. I'm just trying to have our presenter join in, and he says that he's having trouble joining the session. Okay, here he is. Great, fantastic.
Hello, Annie.
Hello, good afternoon.
Good afternoon. Sorry, it was my internet which was very down, so I was struggling with it.
No, no problem. I think we could start because I think we're at 3:11, but I'll also send a reminder to the rest of the participants. We did have quite a number of people interested, so I'm just hoping that it's not the same issue joining.
Can you allow me to share the screen because I can't?
Yes, may I? Okay, fantastic. Maybe if I could briefly talk about, if I could briefly brief the participants of who we are, then I'll have you in coming afterwards, if that's okay. But you should be able to share the screen now. Great. So once again, warm welcome to today's session. My name is Anne Maina. I'm with the Network of Impact Evaluation Researchers in Africa as a program assistant. And we are glad to have you today. So today's session is a presentation. We'll have a presentation from Dr. Wanama Okola. But before that, I could briefly mention of who NIERA is. So we are an independent network of East African scholars who conduct decision-focused evaluations for social and economic development programs across East Africa and beyond. So our work is anchored on 3 pillars, that is evidence generation, policy outreach, and capacity building. Some of you may have interacted with us in previous trainings on impact evaluation, where we aimed to build their capacities on different aspects of impact evaluation techniques. So today's session is tied to our evidence generation pillar that aims to produce demand-driven research that ultimately ties up to our policy-making pillar, and just seeing to it that we influence policy decisions and development programming across the region. So we are currently hosted by the United States International University here in Nairobi, Kenya. And on behalf of the network secretariat and the entire members, we are happy to have you today. So I'll just welcome our member, who is Dr. Wena Maukola, who's been conducting a study, a systematic review on HIV self-testing in Sub-Saharan Africa, just to identify the effective delivery models and how that has influenced the HIV positivity yield and the services as well. So a warm welcome to today's session, and once again, the floor is yours, Dr. Maukola.
Thank you, Annie, and good afternoon, everybody. I think I may share the video if it's so. Should I share, or it's okay if I just
feel free? Feel free to share.
Audio?
Feel free to share.
Let me try because it would be good if you see me. It's a bit darker, but I think you can at least appreciate the face. As Annie said, my name is Wena Maukola. I'm based in Tanzania. I'm a medical doctor by training and a clinical epidemiologist. I'm working with the Ministry of Health Tanzania as a research coordinator. I'll be presenting systematic review on HIV self-testing in Sub-Saharan Africa and focusing on effective delivery models, HIV yield, and the linkage to further HIV services after HIV positive from HIV self-test. So this is an overview of what I'll be going through. You will agree with me, HIV is still a public health problem, especially in Sub-Saharan Africa, where up to 70% of the global HIV burden is. This is just a graph as an example of insisting that HIV is still a problem among us. This is from Tanzania. And this graph shows HIV infection reduction. And the blue line is the target, and the red line is what we have achieved. So you will realize by 2020, we didn't reach the target which was expected to be reached. And in the table, you will also see when comparing between Tanzania and the East Southern Africa and global, and the whole global, you will see, especially if you compare Eastern and Southern Africa versus global burden, you will see the reduction of HIV infection in the region of Eastern and Southern Africa is far behind that of the global. So this showed that the problem is still with us in the region and we need to do something about it. Again, as I introduced on HIV testing, and this slide shows what we have in terms of HIV testing. So again, this is an example from Tanzania. We had a Tanzania HIV indicator survey in 2016 and 2017, and we found that only 52% of the estimated people HIV knew their HIV status, while the requirement was about 90% should know their result by then. And also we had the UNAIDS report in 2020 from our program. And from here, we found that only 83% of the population knew their HIV status. This is Tanzania data, just to show that we are behind for the those who know their status. And for the UNAIDS report by 2020, it was supposed to be 90%, but here we see it was only 83%. So still we are lagging behind. But I just want to emphasize in identifying people living with HIV, the distribution is a bit unequal, and we see some groups of people are more, it's difficult to find them than others. And for this graph, you will see this, the upper blue lines shows for all ages, but if you go for children between 0 and 14, adult males and young people, these are the three groups where the HIV testing is very low compared to other age groups. So in general, HIV testing is lower, but it's more in 0 to 14, adult males and young people aged 15 to 24. But so following this, the UNAIDS actually has recently passed a global AIDS strategy, which will last between 2021 and 2026. And this is actually aiming at ending AIDS epidemic by 2030. And in this global AIDS strategy, we have testing and treatment targets by 2025, which is known as 95-95. I think you have heard about it. And this is nothing but the first 95 is 95% of those who are estimated to have HIV should know their result. It's actually about HIV testing. The second 95 is about treatment. Other 95 is on monitoring HIV treatment. So you'll see that because there has been problems in HIV testing, we now have treatment targets for by 2025 passed by the UNAIDS. So again, if you look at the 95-95 outputs by September 2021, and this is again Tanzanian affair, you will realize that it's just 88% know their status. Still, we have people who are estimated to have HIV, but they have their status. So we need to do something. So as a result of this, WHO and the other players identified the HIV self-testing as a mechanism to have more people testing. And by HIV self-testing is a strategy in which an individual conducts his or her own HIV testing in private and seeks further steps accordingly. If the person finds him or herself to be positive, she is advised to seek for treatment, or even if one is found to be negative, he or she is advised to seek advice for HIV prevention. And HIV self-testing is recommended by WHO, identify more as a means to identify more people living with HIV. And it's especially aimed at those who test for the first time, but even those who repeat can do. And it's designed for people who are most at risk. And studies have shown that there's no associated physical harm in doing this test, because some people were worried that there might be some gender-based device or something like that. But studies have shown that there's nothing associated with them. There's no harm associated with taking HIV self-test. On your left, you'll see one of the HIV self-test. Actually, this is what is currently in our country, and this is using oral mucosa. So the tube on the right is where the gadget on the middle is stored when it's packed, and on the left is the gadget for testing. So actually you use the central thing to scoop some membrane materials from your mouth and drop it in the testing gadget, which is on the left. And results will come out in 20 to 30 minutes. And you have your result. And this is for Tanzania, is used as a screening test. And screening test is not a confirmatory. So if you have a positive result, you proceed to other definitive HIV testing modalities. So why did we do the study? So most countries, including mine, have adopted HIV self-testing. And as you know, anything which is new needs to be consolidated with the evidence. And we all agree that systematic reviews are at the top of evidence generation. As you will see on your right, is right at the top. Systematic reviews are known for creating evidence even after RCTs are conducted. So that's why we used systematic reviews to inform policy around HIV self-testing. So the purpose of conducting the systematic reviews were to document coverage and the effective mode of delivering HIV self-testing to different types of populations. Also gather information on HIV positivity yield following HIV self-test. We also documented the performance of HIV self-testing in linking to other services, including HIV care and treatment services for those who will be found to be HIV positive. So in terms of methodology, such strategy, we used preferred reporting items for systematic reviews and meta-analysis, PRISMA. And the following search engines were used: PubMed, Medline, Embase, and Centrum. And the following search words were used to search materials: HIV self-testing, coverage, mode of delivery, HIV positivity, linkage to HIV service, and Sub-Saharan Africa. So different combinations using N and O were constructed to make sure that all materials around the topic are gathered. And we included both experimental and observational studies. So PICOS. Okay, so we used English language. So all the articles were restricted to English language, and we used for P, the population were adults 15 years and above in Sub-Saharan Africa, and the intervention of interest was HIV self-testing. In comparison, we compared those who received HIV self-testing versus those who received the other modes of HIV services testing, And in terms of outcome, we used the outcome of interest was HIV positivity, model of HIV self-testing, and linkage. And the study designs, as I said, which were involved were both randomized trials and as well as observational studies. So data extraction and management and analysis. Extraction was done by 2 authors, and any discrepancy between the 2 authors were discussed between the 2. And if there was any disagreement between them, there was a 3rd author for decision making. We used a standardized data extraction form, which contained all the information, including the demographic information and the methodology of the studies and the outcome of interest of the study. For outcome of interest, we used adjusted measures and studies which were similar, like in study design, were grouped together. So this is, I think we can visualize. This is a prisma, and we started with, sorry, you can't see, but we started with 7,000 studies, and we navigated through the prisma, and ultimately we had 31 studies which were included in our systematic review. So different exclusions at different stages, as you see, were done so that we remained with the 31 studies. Sorry if you can't see at the bottom, but we had 31 studies remaining at the end. In terms of result, we included, as I said, a total of 31 articles. And in terms of result, the first one was uptake of HIV self-testing, and the coverage was found, or average of 62.25 on all the studies we have gathered. HIV self-testing mode of delivery, we found that most studies were on community models. HIV self-testing happened more in the community than in the health facilities. So this was one of the findings. In HIV positivity yield, we found that up to 74% in HIV self-testing yielded HIV positive results, where using conventional tests only yielded up to 26% in those studies which we pulled. And in successful linkage to HIV services, in those who started with the HIV self-testing, up to 96% actually made to the HIV care and treatment, versus only 42% for those who didn't, who used other conventional HIV tests. So from the systematic review, what I found as conclusion and recommendation is, on the side of conducting systematic review, we need to build the capacity in systematic review, especially on using user-friendly software. I know there are softwares to make the scooping exercise easier, but I think from my own experience, it's very difficult to apply those softwares. So we actually need training for those who want to do systematic review. And on HIV self-testing programming, we found a high uptake of HIV self-testing. So there's a hope for efficient entry point for HIV testing. As I said, HIV self-testing is just a screening test. It's not a definitive test. But as we have seen, those who start with the HIV self-test make it to the end very well compared to those who take other modalities of tests. So as we are struggling with the identification of more people with HIV, it could be an efficient tool to have more people taking HIV testing. And we also found community outlets to be effective mode of delivery. Most people opted for HIV self-testing in the community. So we need to strengthen this service, and I know community services are not very robust in terms of having strong monitoring and evaluation. So if you want to use community outlets, we need to strengthen monitoring and evaluation so that we may know what is going on. And we also found this very successful linkage among HIV self-testing takers. And this actually, to me, looks like those who opted for HIV self-test actually determined to have have service because they made it to the end compared to those who took other tests, those who didn't start with the HIV self-testing. So acknowledgement, I would like to acknowledge Nira, who funded the exercise through Utrecht University, and the National AIDS Control Program is the office I'm working with within the Ministry of Health Tanzania. Asanteni sana, and this is Karibuni sana Tanzania. Welcome to Tanzania. This is Mount Kilimanjaro, and there are lots of national parks where you see all sorts of animals, but zebras are very common. Thank you for your time, and I appreciate your attention in sharing with me the findings from a short systematic review I have carried out. Asante sana, and I welcome any improvement on the report and additional to make my presentation more effective. Asante sana.
Thank you, Dr. Makola, for that insightful presentation. Maybe if I could jump into the questions that we have from the audience, and feel free to post any question, or if you want, if you need Dr. Makola to go back to a certain slide to refresh your mind, we can do that. But if I can start with Tebi Otieno is asking, how does the WHO get data of those who self-test and turn HIV positive, but do not report to the clinic for results confirmation? Dr. Makola, would you want me to go one by one?
Probably, and you were breaking. Can you repeat? Sorry.
Oh, okay.
Oh, in the chat. Probably I can look into the chat.
Okay, we have a question from, I hope I'm audible. Am I?
Yeah, I can hear you now.
Great. So we have a question from Tebi Otieno, who is asking, how does WHO get data of those who self-test, turn HIV positive, but do not report to the clinic for results confirmation?
Okay, thank you very much, Tebi. It's true that as of now, we don't have a mechanism to track those who test, because under routine circumstances, although in some areas they've started something, but you know, HIV self-testing is supposed to be very private, and some people, yes, using mHealth can track results from some people, those who consent, but some people will just take a test and have tests and they keep the results. So it's very difficult to link, but what you can track is how many tests have been distributed. That is the thing you can track, but in terms of results and link it is to how many have been linked into HIV care and treatment and other services is very difficult under routine settings, except in research settings where people consent to do so.
I hope, great. I think we still have another question from Tebi. So in Kenya self-test, he asked, in Kenya we have self-test kits that are not available everywhere. So is this the same case for Tanzania?
Oh yeah, availability is a bit scanty. For here we have consignments. We haven't heard of people complaining stockouts for those who want to get self-test from pharmacies, from health facilities, from community outlets. So I haven't heard anybody complaining. There are probably enough stocks for as of now. Yeah.
So I think Sharon Otieno would like to know which countries were covered by this particular study, the systematic review.
This was Sub-Saharan Africa. Sorry, I didn't summarize this here in terms of countries, but I have it in the main report. Probably I will include in the Word document where I will give a detailed report. There are several countries, Kenya, including South Africa, Zimbabwe, Tanzania, a number of countries which have done HIV self-testing studies.
Great. So we have a question from Tebi. So could Dr. Maokela expound on community outlets? How does it work and what makes it more effective?
Community outlets means we do have, in Tanzania commonly, for here, the setup of community outlets is you have a group of people living with HIV grouped in different, together at a community level. And they may even do economic activities, income generating activities for themselves. And so, and they are a bit organized, and there are several services available in there, including HIV self-test. But the other model which constitute community outlets are those from community health care workers. There are people at the level of communities who are not actually medically trained, but get a kind of training for a short time and carry out some activities at the community. So they also distribute HIV self-testing. The other model which was under community was through mobile services like clinic, outreach clinics. So all these were lumped together as community services, in the sense that that service was delivered in the community versus those services which were delivered at the health facility.
Okay, great. So we do have a question from, I think it's more of a general question from CASA. So in doing systematic review, which softwares are more recommended and how can we apply them for systematic review?
As I said, one of the challenges actually I experienced is using the software which was given to me. And frankly, I used the Mandarin to pull the different articles, and mostly doing check through manually, and the rest doing it manually by looking at the abstracts and titles and going down, sieving all the documents. But there are softwares which are more robust, and if Getouch is around, can also chip in, because he showed some software which make the systematic review easier, but frankly, I didn't use those sophisticated ways of doing systematic review.
Great. Great. We have a question from Tebi Otieno. He asks, some of the people living with HIV in Kenya who are not on medication, that's ART, attribute delay to stigma and denial. What reasons did those who participate in the study in Tanzania say are their reasons for not starting treatment?
Although beyond this, beyond what answer through my study because I pulled studies from different countries in Sub-Saharan Africa. But from my own experience, there are a number of reasons for loss to follow up within the cascade of HIV care and treatment. Some people attributed it to stigma, both external and internal stigma, unavailability of drugs, scarce facilities and things like that. So there are a number of reasons which can be attributed to attrition along the HIV care and treatment, but it was actually beyond the scope of this systematic review to tease out here.
Right. Right. Okay. I think still tied to that is a question on what is the possibility that by 2030 HIV will be eradicated.
The targets actually are made out of some assumptions which are workable. So if what made the targets are actually met, HIV can be controlled by 2030, but if we can't implement what we have planned, we can't reach the targets. So it's all about the targets are realistic. That's what I can tell, and depends on how we implement, to what extent we do. So, and they're not, because when targets are made, they are based on realistic assumptions which can be implemented. So I hope we'll be there.
Right, great. May I invite, I think, one of our members who is present with us today from Ethiopia, that is Getachew. He's clarified on some of the software that researchers can use to conduct systematic reviews. May I invite him to comment a little bit about that? Getachew? Please.
Hi, Anne.
Hi. Great. Please go ahead to contribute.
Okay. The issue about the softwares to use on systematic review and meta-analysis, I think that was a point raised. I was trying to write on the chat box, but so there are a number of softwares we can use. For example, for the systematic review. Systematic review is more of on how to search the articles, on how to select eligible articles using their title, their abstract, and finally using the full text review. So in order to do that, we have a number of softwares like the APPI reviewer software, and we have the Covidence, which is recommended by the Cochrane review, and we have the EndNote software. This one can work offline as well. The EndNote software, it is also used to manage references, so we can also use that for the systematic review. And we have Rayyan software. I have written the spellings in the chat box. So RAYYAN. So this one is free. You can do more than one reviews freely. However, the other softwares require some sort of subscription and license. So we can use all of these softwares to do the systematic review. As you know, systematic review have to be conducted by 2 or more researchers. So you can use the softwares to do this systematic review. For the meta-analysis, the part where you will be analyzing, you will be pulling the finding of several studies together to bring one comprehensive finding. For that, we have softwares like Stata. There is a meta-analysis package that should be installed in the Stata. And once you do that, you can do the meta-analysis using the meta commands And we have also R software. There is also meta-analysis command that should package that should be installed on the R software. It is freely available. And we have the Excel software. Microsoft Excel can also do the meta-analysis, but again, you need to install the comprehensive meta-analysis is also another good software specifically designed for meta-analysis studies. So all of these things can also be used for conducting meta-analysis. Anyway, each of these softwares have their own strengths, benefits, and limitations. And we have also RevMan software. So, for example, when you compare a RevMan and Stata, RevMan cannot do some analysis techniques like sensitivity analysis, meta-regression analysis, which are essential for meta-analysis. But Stata can do that, and other softwares can do that. So some softwares may not do some essential analysis techniques. You can Google more about this information. Thank you, and back to you.
Great, thank you so much for expounding on that. I don't know if you've closed any participant out with regards to the findings presented by Dr. Maukola. The floor is yours before we close the session. And great. I may mention that we will have a number of webinars and workshops coming up, and just to keep you updated on that, please feel free to follow us on Twitter. I've just posted our link there. We are at NIERA_EA, and on LinkedIn we are the Network of Impact Evaluation Researchers in Africa. Just to keep you updated on any programs that we may have, or workshops or webinars on related topics, on different topics, that is, just follow us on our social media platforms or our website as well. We are at the network of, maybe I could post the link as well on that. We do have another webinar on systematic reviews, that a systematic review that one of our members have conducted on gender involvement of women in leadership. So that should be coming up in January. Just so keep an eye on our website or our social media platforms on the dates and time if you're interested in joining. Great. Great. If we do not have any further questions, let me also mention that we'll also share this presentation after this session and the recordings as well, if you'd like to refer some time later. Great. All right, fantastic. Unless Dr. Maukola, you have anything to add?
Thank you, Annie, and the entire office at NIERA in Nairobi, and funders as well, but also to Getachew, who has been taking us through the theoretical parts of systematic review, and everybody who devoted his or her own time in listening to my presentation. I will appreciate any improvement you may write to me. I have dropped an email, or if you don't find one, you can communicate with Annie and I'll get the comments. I appreciate it, and good afternoon.
Great, thank you so much, Dr. Wana, for that, and Getachew for contributing on the software aspects. Thank you all. If you have any questions, feel free to write to myself or Dr. Wana with regard to this presentation, or on any other question that you may have regarding the network. So thank you once again. I'll share the recording and the presentation in the course of the day tomorrow. Asante sana.
Asante, bye.
Bye-bye.
Bye-bye.